Well, hello, everyone. Good afternoon. Welcome to the final session of our practice operations seminar. We thank you, everyone, for joining us. I hope that everyone has had a good couple half days here. I think it's been a real breadth of content, and I hope everyone has enjoyed themselves. I am very pleased to welcome you to our final session. Again, my name is Erin, and on behalf of the Board of Directors, I'm very pleased to welcome you. I want to thank all of our sponsors for our seminar over the past couple days, and I'm especially pleased to thank our final sponsor, Medhelp Incorporated. I am very pleased to welcome their representative now, Turna Nande, who will say a few words. Turna?
Thank you, Erin. And I appreciate everyone for joining us on this call. My name is Turna Nande. I am the sales executive with Medhelp. We're a company based out of Baltimore, Maryland. We're in the revenue cycle and medical billing, have been in this space for the past 3 decades with a proven track record. We work with everything from providers to specialty billing, urgent care, and we also specialize in emergency department denials, appeals, and so forth. So with that being said, I just want to thank you guys again for including Medhelp, and if my contact information is available to anyone who would like to learn more about the company. With that, I'm going to pass it over to Nicole. Thank you.
Thank you. I am very pleased now to welcome our final speaker of our seminar. Nicole Goulden entered the medical coding field in 2014 when she became a certified professional coder with the American Academy of Professional Coders. In 2015, she was fortunate to be hired by Medhelp Inc. for her first coding position. Since then, she's encountered several opportunities within Medhelp to offer her guidance with medical coding to their various clients. Nicole also received her certified documentation expert for outpatients with AAPC in 2020, and we are very pleased to welcome Nicole today. Nicole, you want to share your slides and take it away?
Thank you. Yes. Well, again, thank you everyone for attending. I have some information for you about those wonderful E&M changes that took place in January. Here's my disclaimer, just to let you know it's for educational purposes only. And this presentation is accurate as of April 2021. Okay, so we're on the disclaimer slide. With that, down at the bottom, you see I have updated AMA errata as of March 9, 2021. AMA has come out with some specific revisions to help guide us with some questions since January that we've encountered. Our agenda today, we will be looking at the summary revisions, the AMA tools, how to select the level of service. I have a couple examples for you. We're going to talk about time, prolonged service codes, and ICD-10 updates. That's just a little quick slide at the end there. All right, as you may be aware, our office visit service codes went through a major revision. We now have new guidelines, deletion of 99201, and a new way to select the level of service. Providers now only need to report a medically appropriate history and exam, which are not used to code the level or select that level of service anymore, what we were used to before. The code level now is based on the medical decision-making or time. Next slide. Also, to elaborate a little bit more as to what we will be looking at today, medical decision-making now has an extensive classifications provided in the guidelines to define the elements of medical decision-making. And then time, the total time spent with the patient on the date of the encounter, which now includes non-face-to-face services. There is a clear time range for each code. And then there is a new 15-minute prolonged service code, 99417, which is to be reported only when the visit is based on the time and after the total time of the highest level of service, which is either the 99205 or 99215, has been exceeded. Next slide. This slide is a breakdown as to what components are needed based upon the services provided. Here you will see the new guidelines in column 2. The first column actually are the components. The second column, like I just said, are the new way of doing our medical decision-making level of service. And the third column just talks about the other E&M services, and they have not been changed. So if we just look briefly at, say, history and exam, which I just mentioned, if you look at the second column, it says as medically appropriate, not used in the code selection. The third column, it's still the same. We use the key components, the history, the exam, and the medical decision making. Next slide. AMA has given us some wonderful tools to use, and one of those is definitions. They decided to give us really precise definitions as to what we should be looking for. And here are two examples of the definitions. The detail of all definitions they gave are on pages 12 to 14 of the CPT book. Also, based upon the AMA erratas, I encourage you to review this, and they talk more about analyzed data, unique combination of data elements, and so on and so forth that I have listed there. And just to let you know that I have posted a link at the end of my presentation for these erratas for you to look at, and then also the AMA guide, the tool grid that we're going to look at next. Next slide, please. This is a example, of the tools that AMA has also given us. They've provided us with written guidelines, which is that small box, and then also the medical decision-making table guide. And we're going to look at this table guide a little closer. I'm going to break it down to give you a good understanding of what you need to look at on here to get that appropriate level of service. Next slide. Okay, this is what we are used to, and to recap, excuse me. This is what we're used to looking at, where we're looking for those key components of the history, the exam, medical decision-making, or time, and then what that time rule was. Next slide. So as of January 2021, the appropriate level of the E&M service is based on the following: the level of medical decision-making as defined for each service, or the total time of the E&M service performed on the date of the encounter. And just a little highlight here, the total time refers to the provider time only. It does not include any ancillary staff time, and this is for non-face-to-face and face-to-face time on the day of the encounter. So if I could just highlight a little bit about that. Non-face-to-face is new this year. And if the provider, for example, needs to look at a chart prior to seeing that patient, and the provider uses time to get that E&M service level, he or she can incorporate that as long as it's on the day of the encounter. However, if the provider looks at the chart, say the night before, just to recap before seeing the patient, unfortunately, that time cannot be included in that level of service for that day's visit. Next slide. As I stated, the table will assist you in selecting the level of medical decision-making. It's only used for the office visit codes, 99202 to 99215. One item that hasn't changed is the 4 levels of medical decision-making that you see here, the straightforward, low, moderate, and high. Next slide, please. So what did change? Right here is, you can see these 2 charts, medical decision-making 2020, and then medical decision-making January 2021. So we were used to the number of diagnosis or management options. That changed over to the number of complexity of problems addressed at the encounter. Everything that the patient has to have addressed by the provider on the day of the encounter is what should be in that note and in the medical decision making. That second column talks about the amount and or complexity of data reviewed. Well, now we're adding and analyzed. For the risk of complication and or morbidity or mortality, they've added of the patient management. So what we're doing for that patient's care. Next slide. This here is the medical decision-making grid that the AMA put out. This is a whole, and we will be breaking this down to look at it and understand it a little bit better. Next slide. So here we go. We're going to break it down. The purple header at the top, you see there it talks about the code, level of medical decision making, and then the elements of that medical decision making that I just talked about. The complexity of problems addressed in the encounter, the data to be reviewed and analyzed, and then of course the risk of complications of that patient management. And those elements are really what you're going to be looking at to make sure you get the appropriate information out of that medical decision-making part of the note. Next slide. So the first 2 columns that we're looking at here, the code, you'll see I just have 3 sections listed here, the 99211, the 0212, the 03, and the 13. Now this year, those codes, you don't have to look at it as a new patient or an established patient in the note per se. You have them selected based upon, excuse me, based upon that level of care that you're giving. And with this, that level of medical decision making, you see where I have the red arrow, it's based on 2 out of 3 of those medical decision making elements. And we're getting ready to talk about that. Okay, This third box, the number of complexity of problems addressed at the encounter. This is where you need to make yourself familiar with those definitions that I previously talked about. It will help you with guidance as far as what would be considered a self-limited or minor problem, a stable chronic illness, or an acute uncomplicated illness or injury. Next slide, please. This slide and then the next one that I provide for you, I actually gave you definitions of those situations that I just talked about and some helpful examples to help guide you along the way with that. And for one, let's look at the self-limited minor, that first one. Uncomplicated mosquito bite, uncomplicated diaper rash, follow-up of a resolved condition that was low severity. Things like that you'll look at. Next slide, please. And as we get higher into those levels, I have the definitions for you here. And we'll just take a quick look at one. Acute complicated injury, the fourth bullet down. The examples: worsening headaches or migraines, itis media, forgive me, I always sort of butcher up my medical terminology, always have, but it's just one of those things, unfortunately. And then so on and so forth when they're looking at, lab results and so on. Next slide. All right, now we're into another column, and this is the data to be reviewed and analyzed. This is a little complicated, and there have been some gray areas that the AMA has received questions about, and that's where I think our erratas came from. I will get into that in another slide or two as far as some examples. But this one here, to break it down a little bit for you, it comes into certain categories now. Category 1 talks about your tests, documentation ordered, or independent historian, and these are of unique sources, unique test. And there's independent interpretation of tests that are not reported separately. And when I talk about not reported separately, this means if it's something that you can bill for, you cannot count it in your level of medical decision making. So the little yellow highlights that I've given you here, it just breaks this down a little bit easier. For example, that limited, it requires one of two categories, 2 documents, or an independent historian. So let's talk about that just a little bit further. That category there called limited, right underneath it says must meet requirements of at least 1 or 2 of the categories. You'll see category 1 that talks about the tests and documents, and then there's a category 2, assessment requiring an independent historian. So it needs to have one of those 2. So if we look at category 1 again, it talks about a combination of 2 of the following: a review of prior external notes from each unique source, a review of results of each unique test, or ordering of each unique test. So what that means, you need 2 of those. For example, say the provider ordered 2 different labs. That would actually count as 2 unique tests for that category. Say the provider, it's a pediatrician, talking with the parent of a minor child. That would be considered a category 2. So you would pick what was taking place during that medical decision making based upon what the provider did. And then if you look further into the moderate and the extensive, it'll be a little bit more in detail based upon what that provider needs to do. And then the category 2 under that moderate box talks about interpretation of tests. We're going to talk a little bit further about that in a moment. And then category 3, discussion of management or interpretation of tests. So you'll see in that yellow highlighted area, it says requires 1 category only. You need to count 3 items between documentation, independent historian, or interpreter, or the conference. And then category 5 gets more detailed. You need to have 2 categories for this particular area. Next slide, please. And I broke this down a little bit further for you, gave some definition as to what a unique source might be, a unique test, ordering of a unique test, so on and so forth. With this, I have 3 highlighted note areas, and I just want to address those with you also. And reviewing the results, the first one for each unique test. You cannot report any lab or tests that you do in your office. You must code separately for the lab or test and not add it to the medical decision making. Basically, again, if you can bill for this, you cannot use it to decipher what that level of service will be. When ordering a unique test, I have here, when placing medically necessary order of tests or visit in 6 months, this can be counted as an element of an order on the day that it is placed. And then also that third one, and I found this a little interesting and I wanted to share. If provider A orders and counts the test on the date of the service, provider A does not review the results with that patient. Provider B of the same practice and specialty reviews with the patient. Provider B cannot count this in the medical decision making. Ordering and reviewing are counted together. And as I said before, there is a gray area, and AMA now has looked at it, and I'm sure CMS as well. All right, next slide, please. Here's some more definitions about those categories. And with this, in the independent interpretation of tests, I want to address that again. If you can bill for it, you can't count it. And then also I put an update for the errata. If you would see page 2 of that errata for details of ordering and actual performance and or interpretation of documentation tests during a patient encounter are not included in determining the levels of service. So this talks about professional interpretation. They break this down for us a little bit further since there were so many questions, I believe, that they've had. Next slide, please. Discussion of management or interpretation. So this is in that category 3 of your moderate and your high element for the data review analyzed. Again, here's a definition for you, and if you can bill for it, you cannot count it. Next slide, please. Here's some examples from the AMA errata on the ordering and review that I talked about, and I'd like to go over these with you. In-house testing, not requiring a professional interpretation, say it's a strep test or a urinalysis. You may count, order, or review, but not both. In-house testing requiring a professional interpretation, such as an X-ray. You may not count the order or the review. Just like I stated, if you can bill for it, you cannot count it. Ordering labs by an outside service, outside labs, imaging, X-ray, etc. You may count it in the order. Test provided outside of an encounter. And the example I gave you here, a provider wants different testing after the encounter. Patient didn't have, say, an office visit, but maybe it was a brief phone call saying, let's do another test. You may count this at an encounter where the results are reviewed. So that's something to keep in mind. I'm not sure how often that takes place, but it was definitely addressed. Monthly testing, patients who see a provider monthly for review of a certain test that they have or a condition that they have where they need those review of test results, you may count the review at that encounter. And then another item here that was addressed through the AMA changes, the pulse oximetry test. The AMA states that it's for the purposes of data reviewed, analyzed, and it is not considered a test. So that was something new that they came about also. Next slide, please. Now we're going to move into that last column where we're going to talk about the patient management, the risk. And as you see here, I gave you the classifications, the straightforward, the low, the moderate, and the high. Now, previously, the low risk, we used to have examples. One in particular would be over-the-counter medication. Well, they've decided that over-the-counter medication, even though it was considered a low risk then, they decided that it might not necessarily fall into that category anymore, even though it's an over-the-counter medicine, based upon the decision-making and the patient's condition, whether or not it would be relevant for it to be low. It could be something of a high risk where they need to use an over-the-counter prescription. So there you see that those items previously as examples have been eliminated. However, they did leave examples for moderate and high risk. One in the moderate is that prescription drug management. And also in the high risk, the decision regarding hospitalization. Next slide, please. Okay, here we are looking at this as a whole. Before we stated that column 2, you needed 2 out of the 3 elements to come up with that level of service. Here's an example showing that we had a situation that's one acute uncomplicated illness. Provider felt that it was low risk. However, it looks like as far as data, there was something, maybe there was something minimal or none. But we do have 2 circles in the low category, which would put it at a 0.3 or a 1.3 based upon whether or not that patient's new or established. And this concept has not changed from, current guidelines. All right, next we're going to look at an example. Next slide, please. Here's our example. Mr. Smith presents for a 3-month follow-up of hypertension. He brings his blood pressure diary with him. He reports he has been taking his medication as directed. A clinically appropriate history and exam is documented. His blood pressure is well controlled with medication. Dr. Shelton provides refills and asks Mr. Smith to return in 3 months. Orders were given for the patient to have a BMP and an LFT 1 week prior to the visit. So let's take and break this note apart and see what we come up with. Next slide. So with this, to show you how we're using this grid, we had the patient with hypertension. It was considered well controlled. So we have it highlighted in the number of complexity of problems addressed. It was just the hypertension. I highlighted in yellow, 1 stable chronic illness. The next column over, the elements for the data to be reviewed and analyzed. He ordered 2 tests, a BMP and an LFT. As you see, I highlighted ordering of each unique test. Like I said before, you needed to have any 2 for the following to have this category, and you only needed 1 of the 2 categories. And then also he prescribed or a refill was given for his hypertension. So that's highlighted. You will see, like that previous example, you have 2 areas that are in the same row, the stable chronic illness and then the ordering of unique tests. So that would fall under that low complexity of medical decision making, the 03 or 13. So let's change this up a little bit. Next slide, please. And what about if the provider only ordered a BMP? You need to have 1 of the 2 categories. It does not fall under either one of those categories in the limited area. Category 1, remember, says it's a combination of 2. He didn't talk to an independent historian, so there's nothing there we could use. So you'll see I highlighted minimal or none for that particular category for the review and analyze. So if you can't match what the provider did, then you need to move up the chart to a lower level. It's still hypertension and refill given, but you don't have 2 highlighted in the same column. So then you would look at the one in the middle, which would be still that low level decision making, 99203, or in this case, 13. Next slide. Let's talk about time. There are 2 changes. The limitation on the use of time is deleted. Therefore, the requirement that the visit must be dominated by counseling and/or care, coordination of care, that's gone away for this particular situation. And the time spent now includes the rendering provider's total time spent on the day of the encounter. This includes the non-face-to-face and face-to-face time spent on that particular encounter and patient. And again, it's only the provider's time that's counted, not that ancillary staff time. Next slide, please. Here's some examples as to what can be included as far as the activities that the provider does. Preparing to see the patient, review of tests, like we talked about in the beginning as a brief example. Obtaining and or reviewing separately obtained history, and so on and so forth. I'm not going to read them all to you, but they're there, and this is something that is actually in the CPT book and the AMA guidelines. I do want to draw your attention to two areas here. One is that last bullet that says care coordination. You see in parentheses, not reported separately. Again, if this care coordination is something that the provider can bill for, then you're not able to include it in that time. And then that last item I wanted to address on this page is the updates for the AMA. These are items that the AMA felt should be addressed and clarified based on that errata. These are items that cannot be included for time, and it's 3 here. And again, it's performance of other services that are reported separately. Travel, so if the patient is someplace else and the provider needs to travel to see that patient for whatever reason, travel time is not included. And then that third bullet, it's for the teaching physician, more so. This is teaching that is general and not limited to a discussion that is required for the management of that specific patient. So as an example, the provider talking with the young provider, so to say, they need to talk specifically about that patient and that care. Anything general is not considered part of time. Next slide. So some things to look for in documentation with time. You must have the time that was spent with the provider, or with the patient, my apologies, and details as to what was done with that particular patient and encounter. And that basically says, see that list on the previous slide. Appropriate time statement example. I spent 90 minutes obtaining the HPI, examining the patient, counseling of the patient on diagnosis X. I also scheduled a follow-up with the patient in 3 months. That's a detailed, appropriate time statement. I think that would be something that could be used by all providers if they would like something like that. And then an inappropriate time statement example. I had a lengthy discussion with the patient. I spent so many minutes, supportive counseling, talking about treatment options, or just saying that they were with the patient. These items, unfortunately, are not appropriate for an example to use time. Next slide, please. I have 3 bullets here that talk about what is allowed, what you can bill for, and so on. Providers are not allowed to include the activities performed by that clinical or ancillary staff members, like we talked about, such as taking the vitals in the same in time spent on the visit. The guidelines state that activities performed by the clinical staff are not used to calculate time. And then the 2 other items talk about if it's something that you can bill for, you really cannot count for it in the time. Next slide. We have some new time ranges that were given to us by the AMA. For example, your visits, these are new patient visits. They go from 15 to 29 minutes for an O2. And then, of course, as you get down to the O5, where you're spending more time with the patient based on the decision-making maybe being high, it's about 60 to 74 minutes. So now they've given us a range that we could use. And then here are the time ranges for the established patient visits. I remember that the 99213 previously was about 15 minutes. Well, here they have it broken down from 20 to 29 minutes. So they've increased time for some of these services also. Now we're going to talk about prolonged services. One is the new code that came out. It's the 99417. That is to be used on the 99205 as an add-on or the 99215 as an add-on when the time is exceeded from those codes. And these are 15-minute intervals. So if it's less than 15 minutes of prolonged service, it will not be considered as prolonged. It has to meet that 15-minute mark. And then also CMS decided they wanted to use G2212 in place of that 99417. Next slide. Here briefly, it's just a few of the ICD-10 updates that came out after the October 1, where we can start using the new ICD-10 codes. So I just wanted to briefly share these since they were given out after the fact and became effective January 1. Pay attention to the first one, encounter for screening for the COVID-19. This actually states that you are not to use it during the pandemic. So this is one we're going to wait for, hopefully sooner than later, that this pandemic ends. And then also the second one that I bring to your attention is the contact with and suspected exposure to the COVID-19. This one is now Z20.822. We were using prior to January, I believe it was Z2828 for this classification. So they decided to change it to this particular one, that Z2822. Next slide, please. Right here are some webinar resources that I like to use and I thought I'd share with you. Coding Intel, DonSelf, NAMUS. These are 3 organizations that I follow and they give some wonderful webinars. Some are free and some may have a small fee attached for viewing. But if you're interested and want more information, please check those out. Here's my references. And as I stated earlier, the last 3 bullets, those are the items that I talked about as far as the changes that the AMA came out with, and also the medical decision-making grid that the AMA has given us to use. So those might be a few that you want to definitely try and highlight, and when you have a few moments, take a look at. And I thank you for your time. And here is my email address. If you have any further questions, I'd be happy to answer. Just feel free to contact me. Again, thank you.
Thanks, Nicole. We do have a few more minutes. If anyone has any questions that they'd like to ask Nicole, you can put them in the chat or Q&A box. We'd be happy to take them now. Susan did ask, but yes, all of the slides and recordings from all of our presentations over the past couple days will be sent out over email to all of our registrants. So we will be getting, you can go back over all of our presentations a little slower and read them in a more detailed way in the next few days. But if you have any questions, I'll give another few seconds if you'd like to type any questions in for Nicole. We're happy to take them. I want to thank Nicole and thank Medhelp again for your sponsorship today. Thank Turner for joining us. I really appreciate all of your time and support. I thank our participants today for your patience as we got through our slides. I think it went pretty smoothly, but it wasn't too bad. And thank you, Nicole, again for your time and putting the presentation together. I want to thank all of our speakers and all of our sponsors over the past 2 days. It's been wonderful having everyone join us. I think this was a pretty productive 2 days of learning, and I want everyone to have a great afternoon. On behalf of the Pennsylvania MGMA Board, thank you all for attending and have a great day.
Thank you.